Picture this. It's 3:00 a.m. You're working the night shift in the emergency room. The fluorescent lights are humming. And the coffee has, well, it's long since worn off.
Yeah, we've all been there.
The doors swing open, and you have a 26-year-old man who looks absolutely miserable. He's dehydrated. He's been vomiting for 3 hours, and he's clutching his side, complaining of this agonizing, painful swelling in his left groin.
It's a classic presentation, but one that always raises the blood pressure of the attending physician.
Exactly. You examine him. His abdomen is distended tight like a drum, and there it is, a large, tense mass in the groin that extends right down into the scrotum.
Mm-hmm.
You try to gently push it back in, what they call reducing it, but it won't budge. It is rock hard.
And right there, the clock starts ticking.
The diagnosis: a left complete, irreducible, indirect inguinal hernia. And the vomiting, that's because loops of his bowel are trapped inside that hernia, literally being strangled.
The plumbing is blocked. It's a mechanical failure of the highest order.
Yes. And that is what brings us to today's topic. We often think of the abdomen as just, the stomach or the belly, a soft place where we store food.
Right.
But that hernia tells a different story. It tells us that the abdominal wall isn't just a wrapper, it is a high-pressure containment system.
A very sophisticated one.
Yeah.
And when that containment system fails, as we just saw with our 26-year-old patient, it can be life-threatening.
So our mission today is to map the container. We are going to perform a deep dive into the anterolateral abdominal wall. We aren't just memorizing names here. We're trying to understand the architectural layers that keep our insides, in.
And to do that, we're turning to a classic. We're diving into the abdominal wall chapter of Snell's Clinical Anatomy.
Yes, the legendary Snell's. Now, a quick disclaimer before we start cutting into the layers. We are interpreting this chapter to build a mental scaffolding for you. This is not a regurgitation.
No, we're not just reading the phone book to you.
Definitely not.
Please, no. The goal here is to make you curious. Reading the actual text is becoming a bit of a lost art, and there's nuance in those pages that we just can't fully capture in audio.
That's so true. Think of this deep dive as your ready reckoner. We want to give you the metaphors and the clinical anchors so that when you do open the book, and you should, the information sticks like glue.
Exactly. We want you to finish this and say, okay, I need to see the diagram of that rectus sheath right now.
Yes. So let's build the house. Every good house needs a frame. Before we hang the drywall, which I guess would be the muscle.
The muscles.
We need to check the studs.
That would be the osteology. The bones. And what's striking about the abdomen, especially compared to the chest, is how little bone there actually is.
It's a bit exposed, isn't it?
Very. In the thorax, you have ribs protecting everything, the heart, the lungs. But in the abdomen, the front is wide open.
So what are the rigid supports?
The only rigid supports are the pillars in the back, the 5 lumbar vertebrae. And Snell makes a point of describing them as massive and kidney-shaped.
Kidney-shaped. Why that specific detail? Is that important?
It's pure engineering. The bodies of the vertebrae have to be massive because they're supporting the weight of the entire upper body, plus, whatever you happen to be carrying. But they also have these long transverse processes that stick out like wings.
Okay.
And those are crucial anchor points for the muscles we'll talk about later.
All right, so we have the pillars in the back. What about the roof and the floor?
The roof is the costal margin. That's the cartilages of ribs 7 through 10 meeting in the middle at the Cepheid process. That's that bony point right at the bottom of your sternum you can feel.
Got it. And the floor, or I guess the basin.
The basin is the pelvis. Specifically, we care about the iliac crest. That's the rim of the hip bone you can feel on your sides.
Yeah.
Follow that curve forward, and you hit a bony bump called the anterior superior iliac spine, or ASIS.
ASIS. Okay, remember that acronym, everyone listening? It's going to be our GPS coordinate for a lot of things today.
It is. It's a huge landmark. And then down the center, you have the pubic tubercle and the symphysis pubis. These bones are the only rigid protection we have. Everything else spanning that gap is soft tissue.
Which explains why the wall is, as the text says, essential for support. If the muscles fail, the organs have nowhere to go but out.
Precisely.
Now, before we cut into the meat, let's look at the surface, the canvas, if you will.
Surface anatomy is vital because, unlike a textbook diagram, patients don't come with labels. You have to map the unseen by looking at the seen.
And Snell gives us this grid system using dermatomes.
Right. A dermatome is just a strip of skin supplied by a single spinal nerve. And look, you don't need to memorize every millimeter, but you absolutely need the anchors.
Give us the anchors.
Okay, top, middle, and bottom. The top anchor is T7. That's located right over the xiphoid process, that bony point we mentioned.
T7 at the top. Got it.
The middle anchor is T10. This is the easiest one. T10 is the umbilicus.
The belly button.
Yep. The mnemonic everyone uses is belly butt 10, T10.
Belly butt 10. It's terrible, but I'll never forget it.
It works. And the bottom anchor is L1. This is the strip of skin just above the inguinal ligament and the symphysis pubis, basically the groin area.
So T7 myxosphoid, T10 belly button, L1 groin. Why does a listener need to care about this? What's the clinical tie-in?
Because pain is a map. If a patient comes in complaining of burning pain or numbness in a specific horizontal strip right across their belly button, you don't just guess.
You know?
You know immediately that's the T10 spinal nerve. It tells you exactly where the problem might be originating in the spine. It's like having coordinates.
Okay, we have the frame, we have the surface grid. Now let's get surgical. We're going to do a virtual incision. To get into the abdomen, say, to take out an appendix, how many layers do we have to cut through?
7. It is exactly 7 layers.
It's a 7-layer dip of the abdomen. I like that. Let's scoop through them one by one. Layer 1 is obviously the skin.
But even the skin has rules. Snell discusses Langer's lines or cleavage lines. These are the directions that the collagen fibers run. In the trunk, they run almost horizontally.
This sounds like a practical tip for the surgeons listening.
Oh, it is. It is the difference between a beautiful thin scar and a wide, ugly one.
How so?
If you make your incision horizontally, along with the fibers, the wound stays closed naturally. The tension is minimal. If you cut vertically across the fibers, the tension pulls the wound open constantly. It heals poorly.
So follow the grain of the wood. Got it. Layer 2 is the superficial fascia. Now, usually superficial fascia is just a fancy word for the fat under the skin.
Right.
But in the lower abdomen, something weird happens. It splits.
It does. It develops a split personality. It divides into 2 distinctive sublayers. The top one is the fatty layer called Camper's fascia.
I use a metaphor for this one. When I think campers, I think camping. And camping means marshmallows, which are soft and fatty. So campers is the fat.
That works perfectly. But underneath that fat is the second sublayer, Scarpa's fascia. This is the membranous layer. It's thin, but it is tough. And it is incredibly important for one specific, slightly horrifying reason.
Ah, this is the urine trap concept. I found this fascinating.
It is a critical piece of anatomy to understand. We have to look at where Scarpa's fascia attaches. It goes down the belly, and then it fuses with the deep fascia of the thigh, the fascia lata, just below the inguinal ligament.
So it's like it's tucked in at the top of your thigh.
Exactly. It creates a seal. Now imagine a traumatic injury. A man is in a motorcycle accident and ruptures his penile urethra.
Okay, that is a bad day.
A very bad day. Urine starts leaking out of the urethra. That urine fills the spaces available to it. It fills the scrotum. It fills the penis. And then it starts moving up. It travels up underneath Scarpa's fascia, spreading across the abdomen.
Okay, so here's the check-in question for the listener. Why doesn't the urine run down the legs? I mean, gravity would say it should go down towards the knees.
But anatomy says no.
Why not?
Because Scarpa's fascia is fused to the thigh fascia. It creates a watertight seal right at the top of the legs. The urine hits that wall, and it can't go down. It has no choice but to be forced upward into the abdominal wall.
That is such a vivid image. So if you see a patient with a swollen scrotum and a red, tender lower abdominal wall after a pelvic injury, you're literally seeing that fascial map in action.
Precisely. It's Scarpa's barrier.
Okay, moving deeper. We've gone through skin, Camper's, and Scarpa's. Now we hit the muscles. This is the engine room. And we have a specific design here. It's like a tire wall, right? Layers running in different directions for strength.
That's the plywood principle. Absolutely. You have 3 flat muscles stacked on top of each other. The outermost one is the external oblique.
How do we recognize it? What's the tell?
The direction of the fibers. They run downward and medially.
The anchor here is hands in pockets. If you put your hands in your jacket pockets, your fingers point down and in. That is the direction of the external oblique fibers.
Hands in pockets is the universal anchor. It's perfect. But the external oblique does something special at the bottom. The lower edge of this muscle's tendon, its aponeurosis, actually rolls under itself.
It folds back.
It folds back to form a thick structural cable.
And that cable is the inguinal ligament.
Correct. It stretches from the acis to the pubic tubercle. It's not a separate structure. It's just the folded edge of the external oblique.
And right above the pubic tubercle, there is a triangular gap in this muscle.
There is. The superficial inguinal ring. A literal hole in the armor.
A necessary hole, though.
A necessary hole. The spermatic cord has to get out somehow. But a hole is a weakness, and that's where hernias happen.
Okay, so let's peel back the external oblique. What's waiting for us underneath?
The internal oblique. And its fibers run upward and medially, so they're perpendicular to the external.
So they create a crosshatch pattern. Very strong. Now, Snell mentions a cool connection here with the spermatic cord.
Yes, this is great. As the spermatic cord passes under the internal oblique during development, it reaches up and grabs some of the muscle fibers, dragging them along with it.
So it pulls some muscle down with it?
It pulls them right down into the scrotum. These dragged fibers become the cremaster muscle.
The muscle that surrounds the testicle.
Right, and because it's derived from the internal oblique, which is a skeletal muscle, the body controls it reflexively. It raises and lowers the testes for temperature control. It's a direct extension of the abdominal wall.
That's incredible. Okay, so deep to the internal oblique, we find the third layer, the transversus abdominis.
And the name tells you the direction. The fibers run transversely or horizontally.
This is the corset muscle.
Exactly. Its main job isn't to move the trunk, it's to compress the contents. It squeezes. And there's an important navigational note here for anyone with a needle. The nerves, those T7 to L1 nerves we talked about, they run in the neurovascular plane.
Which is where, again,
It's between the middle layer, the internal oblique, and the deep layer, the transversus.
so it's a sandwich.
It's a sandwich. It's exactly the same setup as the intercostal nerves in the ribs. So if you are a surgeon doing a nerve block, that is the layer you're aiming for.
Okay, we have the three flat muscles on the sides, but what about that six-pack in the middle?
That's the vertical strap, the rectus abdominis. It runs straight up and down, separated in the middle by the linea alba, the white line.
And the six-pack look? That's not just from the gym.
No, it's anatomy. The muscle is interrupted by what are called tendinous intersections, usually 3 of them. These fibrous bands tether the muscle to the front layer of its sheath.
Ah, so it's attached to the covering in front.
Yes, and that's what creates the segmented look.
Before we move off muscles, there is a tiny one Snell mentions. The pyramidalis. Is that important?
Ah, the pyramidalis. It's a small triangular muscle at the very bottom, inside the rectus sheath. It attaches to the linea alba and tenses it. To be honest, it's absent in a lot of people.
So it's an evolutionary leftover.
Sort of, yeah. But surgeons use it as a landmark, so it's good to know it's there, or might be there.
All right, we have built the muscle wall. But nature didn't just leave these muscles hanging. It wrapped them in a very complex envelope called the rectus sheath.
And this is where students often get lost. The rectus sheath is formed by the tendons, the aponeuroses, of those 3 flat muscles we just discussed.
And they wrap around the vertical rectus muscle like a sleeve.
Right, but the logic of the wrapping changes depending on where you are in the abdomen. It's not uniform.
It's a shifting envelope.
That's a great way to put it. Snell breaks it down into 3 zones, but the most important transition happens at a place called the arcuate line.
Let's unpack this changing logic. Let's start with the main belly area, zone B, from the ribs down to this arcuate line. How is the rectus wrapped there?
In this middle zone, the internal oblique tendon, that middle layer, does something clever. It splits in half.
It splits.
One sheet goes in front of the rectus muscle, and one sheet goes behind the rectus muscle.
So the rectus is hugged on both sides by the internal oblique.
Yes. And then the external oblique joins the front layer, and the transversus joins the back layer. So you have a perfect balance. 2 layers in front, 2 layers behind. Strong, secure.
But then we hit the arcuate line. And you said this is about halfway between the belly button and the pubic bone. What happens there?
The rules change completely. Below the arcuate line, all 3 muscle tendons, external, internal, and transversus pass in front of the rectus muscle.
All of them. They all go to the front.
Every single one. They all gang up on the front.
So what is behind the rectus muscle down there?
Nothing. Well, no tendon. The muscle sits directly on the transversalis fascia, which is the next layer in. The posterior wall of the sheath just disappears.
That sounds like a design flaw, or at least a vulnerability.
It creates a specific clinical risk. There are blood vessels running inside that sheath, the inferior epigastric vessels.
Okay, let's do a case study here. The hematoma case.
Right. Imagine a patient, maybe an elderly person on blood thinners, who has a severe coughing fit. Or maybe someone who gets kicked in the stomach. Suddenly, they develop a painful, tender mass below the belly button, confined to one side of the midline.
What happened?
The violent muscle contraction sheared those inferior epigastric vessels. Because there is no strong posterior sheath below the arcuate line to contain the bleeding or protect the vessels.
The blood just pours out.
It pours out into the space, creating a rectus sheath hematoma. And because the sheath is so strong on the front, the blood has nowhere to go but to form a tense mass that can actually mimic a tumor.
Wow. So knowing that the posterior wall is missing down there explains exactly why these vessels are so vulnerable in the lower abdomen.
Exactly. If you're examining a patient's belly below the umbilicus and feel a mass, you have to think about the arcuate line. It might just be a bleed.
Let's move on. The high-stakes tunnel, the inguinal canal. This is probably the most confusing part of abdominal anatomy for 90% of students.
It is notoriously difficult, but it makes sense if you think about movement. The inguinal canal is not just a hole drilled through a board. It's a tunnel formed by migration.
The migration of the testis.
Correct. In the fetus, the testis starts inside the abdomen, way up high near the kidneys. It has to get out to the scrotum. To get there, it has to push its way through the abdominal wall.
I love the analogy of a finger pushing through dough.
That's exactly it. Imagine the abdominal wall is layers of dough. If you push your finger through, you don't break the layers, you stretch them out, coating your finger in each layer as you pass through it.
This is the onion layer concept. The spermatic cord gets its coverings from the layers it punches through. Let's track the journey.
Okay. The testis starts inside. The first layer it hits is the transversalis fascia, that deepest lining. It pushes through and creates the deep ring.
And what does it take with it?
It stretches the transversalis fascia into a tube, which becomes the internal spermatic fascia. That's the first covering.
Well,
the innermost layer of the onion.
next layer out would be the muscles, so it hits the transversus abdominis next.
Yeah, that's a trick question. It actually doesn't take a layer from the transversus. The transversus muscle arches over the canal. It creates a roof, but the testes passes under it so it doesn't give a coating.
Okay, so transversus is a bystander. It just watches. What about the internal oblique?
It pushes past the internal oblique. And we already mentioned this. It drags muscle fibers with it. This becomes the cremasteric fascia and muscle.
The second covering. Got it. And finally, the external oblique.
It pushes out through that triangular gap we saw earlier, the superficial ring. As it exits, it takes a layer of the external oblique aponeurosis with it, which becomes the external spermatic fascia.
So let's just recap the onion. Transversal asci fascia becomes internal spermatic fascia, internal oblique becomes cremasteric fascia, and external oblique becomes external spermatic fascia.
And transversus abdominis gets skipped. Perfect. And that tunnel, that diagonal passage through the layers, that is the inguinal canal.
But wait, if there is a hole through all these layers, why don't our guts fall out every time we cough?
Great question. It's because of the conjoint tendon. Remember how the internal oblique and transversus arch over the canal?
Yeah.
Behind the superficial ring, the exit? Those two muscles fuse together to form a strong tendon that reinforces the wall right behind the weak point. It acts like a shutter.
A shutter.
Yeah, when you cough, the abdominal pressure increases, those muscles contract, and they clamp down on the canal, closing it off.
It's an active valve. Unless, of course, that mechanism fails, and then we're back to our 26-year-old hernia patient.
Exactly. Understanding the deep ring and the conjoint tendon is the only way to understand how to fix that hernia.
We're in the home stretch here. Wiring and plumbing, nerves and vessels. We already touched on the nerves in the sandwich plane. Let's talk arteries.
The main story here is the connection. You have the superior epigastric artery coming down from the chest, from the internal thoracic, and you have the inferior epigastric coming up from the legs, from the external iliac.
And they meet.
They meet in the middle, inside the rectus sheath, and they basically kiss, the anastomose. This provides a backup blood supply. If the aorta were blocked somewhere in between, blood could theoretically travel through this detour.
Very cool. Now, veins, there is a concept called the watershed.
Yes, at the umbilicus. It's like a continental divide. Veins above the belly button flow up to the armpit, to the axillary vein. Veins below the belly button flow down to the groin, to the femoral vein.
But there is a spooky clinical sign associated with the veins here, the caput medusa.
Medusa's head. This happens when the liver is blocked, like in cirrhosis from alcoholism.
Yeah.
The blood can't get through the liver, so it backs up. It forces open these small veins around the belly button, the paraumbilical veins that connect to the skin.
And what does it look like?
The veins on the belly gorge with blood. They radiate out from the belly button like snakes. It looks exactly like the head of Medusa. If you see that, you know the patient has serious liver portal hypertension.
Snakes on the belly. Anatomy is wild. Okay, we have covered a massive amount of ground. Let's do a rewind and review challenge to see if you were listening.
Ready.
Okay, everyone, visualize the layers. I am a surgeon. I make an incision exactly midway between the belly button and the pubic bone. I cut through the skin, the fat, the anterior sheath, and I move the rectus muscle aside. What layer is immediately behind the muscle?
Think about the zones. We are below the belly button, which means we are below the arcuate line,
The answer is?
the transversalis fascia. Because below the arcuate line, there is no posterior rectus sheath. The muscle is sitting right on the fascia. If you said posterior rectus sheath, you need to rewind.
Let's do one more fictional case study to synthesize this.
Go for it.
A 40-year-old woman presents. She has had multiple pregnancies. She has what she describes as a pendulous abdomen. The lower belly is hanging forward. She is worried it's a tumor.
Okay, this is a condition often called visceraptosis, and it brings up the importance of muscle tone.
So how do you differentiate this from a tumor or just fat?
Well, it's about the integrity of the abdominal wall muscles. After multiple pregnancies, the obliques, and especially the transverses, can become stretched and weak. They fail to support the viscera. The corset fails.
So the guts essentially flop forward against the skin.
Exactly. But you have to rule out other things. And this brings us to something called the abdominothoracic rhythm.
What is that?
Watch her breathe. Normally, when you take a deep breath, your chest expands and your belly moves out. That's normal rhythm.
Okay.
If the belly does not move out, or if it sucks in when the chest expands, that is a huge danger sign. It means the muscles are rigid. They are guarding.
And guarding implies?
Peritonitis. Inflammation of the parietal peritoneum lining the wall. The muscles freeze up to protect the inflamed tissue underneath. So a floppy belly is muscle weakness. A rigid, non-moving belly is a surgical emergency.
That is a crucial physical exam, Pearl.
It really is. Can save a life.
We have mapped the container. Let's summarize the key takeaways from this deep dive into Snell's chapter on the abdominal wall.
Okay, takeaway 1. The wall is 7 layers deep. Don't skip the fascia.
Takeaway 2. Scarpa's fascia is the gatekeeper. It fuses to the thigh, which prevents fluids like urine from running down the legs, forcing them up into the belly instead.
Takeaway 3. The arcuate line is the cliff edge of the rectus sheath. Below it, the posterior wall vanishes, leaving the blood vessels vulnerable to shearing.
And takeaway 4. The inguinal canal is a tunnel created by the testis moving house. It drags the fascial layers with it to create the coverings of the cord, the onion rule.
And if you connect this back to our 26-year-old patient from the intro, the guy with the vomiting and the hernia.
The hernia is basically a failure of that shutter mechanism. The bowel found the weakness, probably the deep ring, and pushed through, following the exact path of the testes.
Precisely. The anatomy is the pathology. You can't fix the hernia if you don't know the layers it pushed through.
Here is a little provocative thought for you to mull over. We talked about normal anatomy, but think about the embryology hidden here.
Oh, this is a good one.
Every time you examine a spermatic cord or look at a hernia, you are looking at a ghost. The layers of that cord, the internal spermatic, the cremaster, the external spermatic, they are just the abdominal wall muscles stretched out into a tube.
It's true. A hernia sac is essentially the inside of the abdomen turning itself inside out. You are literally touching the peritoneum just in the wrong place.
It changes how you see the body. It's not static, it's plastic. It's a story of development.
And that is why you need to read the book.
Yes. Do not let this be the end. Go open Snell's Clinical Anatomy, find the chapter on the abdominal wall, look at the diagram of the rectus sheath, verify the hands and pockets orientation of the external oblique. Make the knowledge yours.
Anatomy is a visual sport. We've given you the commentary. Now go watch the game.
Thanks for diving deep with us. We'll see you on the next layer.
Stay curious.